And share my screen. All right. So, good evening. I thank you all for coming tonight to the Nassau County Dental Society's live webinar, Restorative Driven Endodontics, a Paradigm Shift. I'm Gene Porcelli, and before we begin, there's a few business items to review. The webinar is being recorded and will be saved on our website under the webinar archives. I've muted all the participants. If you have any questions during the lecture, you can type your questions in chat or click raise hand. After the lecture, I will read the questions in chat or I will call on those with a raised hand, ask you to unmute yourself so that you can ask your question. To find the chat area on a computer, hover your mouse over the presentation and you'll see the chat icon at the bottom of the screen. Click on it and the chat window will open. Type your question and click send to everyone. To find the chat area on a mobile device, touch the screen, click the three dots with the word more, and in the pop-up, click chat. On a cell phone, after you click send, you'll need to then click close to return to the slide presentation. To raise your hand, hover your mouse over the presentation and click the reactions button that has a smile face icon. Click on it and you will see raise hand. To find this on a mobile device, touch the screen, touch the three dots, and with the word more, and then touch raise hand. All right, there are 4 requirements to receive CE credit for the course. You must be registered for the webinar. You must be identified by name during the Zoom meeting. Okay, that means the box shouldn't say Joe's iPhone, it should say your name. You must type your name in the chat area, and you must submit the evaluation form on the day of the lecture. As I said, to receive credit, you must type your name in the chat area and have your name showing in the login box. If your login name is not your first and last name, you can rename yourself. You do this by either finding your login name in the participant list or your box on the screen. Click on the 3 dots, click rename, and then type in your first and last name. The link to the evaluation form will be presented at the end of the lecture. In a few days, you'll receive an email with verification of course completion. This is only for your records. I will submit for CE credit for all the participants who meet the requirements. So tonight's sponsors are Fox Pest Control. They're locally managed and operated, offer free inspections and same-day service, and Tech-A-Go-Go. Service at the speed of need. They're a free software company that connects dental offices to service techs to do same-day repairs, kind of like Uber for your dental equipment repairs. Save time, money, and hassle. You'll hear more from both of these sponsors at the conclusion of our lecture. As I said, today's live webinar is Restorative Driven Endodontics, a Paradigm Shift, presented by Dr. Marcus Johnson. Dr. Johnson is a Rutgers University alum and graduate of New York University Dental School. He received a certificate of endodontics from Case Western Reserve University in Cleveland, Ohio, while earning his master's degree in science and dentistry. He is an intellectual and progressive-minded clinician and won an award in 2011 from the American Association of Endodontists for his research on new treatment techniques with endodontics. Dr. Johnson is on staff at Interfaith Medical Hospital in Brooklyn, New York. His responsibilities as the endodontic attending include lecturing, teaching dental students, and management of dental trauma emergencies. He is a key opinion leader and official speaker for Colteen, a dental equipment manufacturing company. He lectures nationally and internationally on current trends within endodontics, endodontic products, and provides continuing education courses for dental professionals. Dr. Johnson is an active member of numerous organizations, including the American Association of Endodontists, American Dental Association, National Dental Association, as well as the New York State Dental Association. Dr. Johnson served as a volunteer treating communities abroad on outreach programs to Jamaica with his alma mater, NYU, providing free care to those most in need. In addition, he founded Operation Dental Success, a program in which he lectures to local students, highlighting dentistry as a career while promoting proper oral hygiene. We're very honored to have him here tonight. I'm sure you'll enjoy the lecture. And now I introduce Dr. Marcus Johnson. screen. Marcus, you can share yours and begin whenever you're ready. You need to unmute though. So Marcus, we're not hearing you. You need to unmute your phone.
Okay, can you hear me now?
Perfect.
Perfect, okay. Thank you so much, Eugene, for the warm welcome. It is a pleasure to be here with so many of you from Nassau County on this Wednesday evening. I really appreciate the invitation to speak with you and really just share my passion. Dentistry has been something I've been fond of since the age of 11. And bless the Lord, he allowed me to continue along that path and that journey. And here I am presenting on endodontics this evening, and hopefully have some engaging ideas to share with you, and just come from a perspective of really what I feel works best for me and where I see the profession moving towards, and really providing patients with the best patient-centered outcomes for optimum care and longevity of the endodontically treated tooth. So, of course, I would be remiss if I were not to extend a sincere hand of gratitude to everyone at the Nassau County. Thank you so much for inviting me to speak, and of course, President Joe Grossi, Mr. Give Kids a Smile himself. I missed it this year, but I'm always happy to lend a hand. And this month is Black History Month. I feel that I represent the best in dentistry regardless of that, but nonetheless, it is a time of celebration to acknowledge individuals who may not always have that element shining on them. And so thank you to Fabiola, Dr. Fabiola, for really having some insight, as well as Don Hills, in bringing a new resolution to NISDA so that we can really celebrate any and everyone's contributions, as we know that the best way to elevate dentistry is through diversity. And I believe we're doing that here this evening. So thank you so much. I also wanted to say that I am a KOL for Tolkien. They are sponsoring. However, this is not a sales pitch. I really just want to speak to you from a place of sincerity so that you can understand how I practice and possibly learn something, and we can sort of just have a general discourse and conversation about endodontics, more over the dynamic shift that we see known as endo-resto. And so I guess I'll just go ahead and get right into that, just to kind of outline where the discussion will flow from this evening. If we really look at classic literature, we understand that the foundational dichotomy of dentistry still holds true. And that is that the restorative is just as important, if not more important, than the endodontic. And so what I've been able to do within my practice over the past years since I came out in 2001 from Case Western in Cleveland, Ohio, was treat patients with the end in mind. And I tell you, that has been such a transformative experience for me. It's really helped me as a clinician to better understand, just the different ways to extend the longevity of the natural dentition. I think we find that patients are eager to save their natural teeth. And even in the age of dental implants, we understand that dental implants are a viable option when the natural tooth cannot be saved. But even from the American Association of Endodontics position paper, we still strongly advocate for patients to save the natural dentition, and they should look to dentists, but more specifically endodontists, as the specialists in managing pain and saving the natural dentition. So that's kind of what we're going to be talking about, and I'll be highlighting a few cases and also just giving a brief overview of some studies that I find are relevant and touch on some basics, because you cannot perform good endodontics if you do not have profound pulpal anesthesia. So we'll revisit some of those conversations as well. But essentially, we have to understand that the restorative arm of endodontics is oftentimes overlooked. We have a myopic view And as endodontists, I believe that there is a strong cultural shift, specifically amongst clinicians 10 years and out on social media platforms and different areas of different platforms of learning. And we see that dental conservation is in, saving teeth is really what matters. And at the end, we just want positive, good patient outcomes. So let me advance the slide. There we go. Thank you again to Executive Director on the very nice introduction. I'm a very humble individual, but I always feel that excellence must be the standard. So you can feel free to look at my resume there. And I'll tell you, I'm very passionate about what I'm speaking on this evening. And I just recently put together a introduction page for Dental Product Shopper, as you can see is noted right here. And just really talking about the shift that we're seeing and how changes in files, metallurgical sort of advances, transformative access designs, new endodontic materials, bioceramic cement, magnification, imaging, so many different technologies and modalities allow us to really practice at a higher level and really save teeth in new fashions beyond what we once thought was possible. As you know, this is a February, and I did just want to point and make a note of distinction, considering that it is Black History Month, and we kind of want to acknowledge the contributions of all individuals, but on this month, oftentimes it's nice to draw highlights of some other individuals who have contributed to the profession. Many of you may not know, I have been a New York transplant for at least 20 years now, but originally I'm from Denver, Colorado. My grandparents were civil rights activists out of Mississippi, and we migrated west when civil rights, activity was at its peak, and they wanted to keep my mom safe. So we found safe haven in Denver, Colorado. And one of my earliest inspirations of pursuing dentistry was from Clarence Fitzgerald Holmes, who practiced roughly around the 1920s and on. And he was noted as not being the first licensed Black dentist within Colorado. That distinction actually goes to Thomas Ernest McLean, but he was the first dentist to join the Denver Dental Society. So I think it's pretty impressive that I'm here speaking to you all from the platform of the Nassau County Dental Society. And so he was the first. You can see his picture in his office. And so understanding that history, it kind of gave me a purpose and a sense of belonging that, hey, you know what, this is something that I can pursue. And I always try to impose that upon the young minds that anything is possible, but sometimes you may need a mentor or some sort of guidance to step into that. And I see one of my teachers, one of my mentors on this evening, Dr. Weiner from NYU. It was a pleasure to speak to you before, and so many others who have helped me along the way. And none more than my mentor who I worked for once I graduated from Case Western in Cleveland, Ohio, Dr. Al Granger. Many of you may know him, and him and his great endodontics of Long Island. So just want to comment to him. The path that I'm on right now is definitely in response to the tutelage I received under him, and he is strong, and it's just nice to be back. So when I first set upon my practice, and I said, how am I going to develop a treatment philosophy that separates me from my colleagues, but still allows me to pursue excellence and provide quality care in a timely fashion, but more or less in a fashion where I felt that there was no really distinction between the endo and the resto of the case. And so there's a word in Swahili which means kujichagulia. And please do repeat that. It takes a little while to get it right. But kujichagulia has a very powerful meaning, and it stands for knowledge of self, self-determination. So essentially, when you can kind of understand and develop a treatment philosophy and bring that to your team, be a team leader, bring that to your patients, bring that to the community, it really just helps you flourish. I have definitely benefited from that. So understanding the value of Kuji Chagalia, and knowing where I've come from to try to better understand and map my road forward. I think I do see a hand that is raised. If there are any questions, feel free. This is an open discussion. I'm just may not be as savvy in how to address your question, considering that it has been 2 years into the pandemic. I really would prefer to be speaking to you in public. I feel that my presentation is much more dynamic, and my mom say that I'm much more handsome in person, but of course, all moms would say that. But of course, the biggest room, and my father was a military man, and he used to always pose the question to me in the morning. He would have us up very early doing push-ups, reading, just really drilling discipline in us. And he would always ask me, son, Marcus, what is the biggest room in the world? And at first I didn't know. I said, I don't know, Dad, it's the living room. He said, no, the biggest room is the room for improvement. So I'm always on a quest to get better. I'm always on a quest to improve, never in pursuit of perfection, because none of us are perfect, but I am always in pursuit of excellence. And I think that you can't miss too far from perfect when you put excellence on the pedestal. Preparation plus timing equals success, putting in the time, studying, so that when the test comes, you can actually deliver. And the best guiding light, the advice that I received from my chairman in Case Western, Dr. Andre Mickle, the mother litmus test. If this were your mother, what would you do? And it's really just that simple. Pardon me. Now, if you don't love your mother, or you guys have some challenges, that may not be the best way to gauge how you're going to treat your patients. But nonetheless, the mother litmus test has been a standard and a staple within my practice. So just look at this diagram. I love diagrams because what they do is they provide a visual illustration of really what's going on. And you'll be listening to me talk this evening, but I do have a lot of cases that I just want to highlight because most of you, I learn best from discussing cases and looking at ways where I could have improved. What did I like about this case? Sharing it with other colleagues. And I feel that's what's the value in dentistry. I think we all have a very welcoming platform, and I've learned so much from so many individuals. And specifically, since we've gone through the pandemic, it has kind of put us on warp speed into the new classroom, which is online and virtual and social media. And so I encourage you, if you are not involved with these forums, just to take a look and understand that there's so much dentistry going on, a lot of good dentistry. Of course, there's a counter of that, maybe some dentistry that is not as good. But as long as we keep learning and sharing and really trying to understand the dynamic of teeth in itself, we really can't lose. And so we're going to be discussing tonight the term minimally invasive endodontics. I'm sure some of you have heard of that, dentin conservation techniques. I personally like to coin the phrase minimally engaging endodontics because we really are trying to find out ways to engage as little of the tooth as possible and respect the natural anatomy. And that's really what we're kind of seeing is we're revisiting how can we clean and shape canals and properly restore the tooth to a functional state, but respecting the original anatomy. So when we look at this diagram here, we can pretty much see what we most would think that, okay, you have some decay, drill and fill. Some people say that endodontics is no more or less than just, filling an open space. It's the art and science of filling an open space. I tend to think it's a little bit more involved than that. Of course, filing and shaping, obturation, and then maybe placing some sort of reinforcement like a post, and then of course, final restoration. And we're going to get into the discussion. What does final restoration really mean? When we talk about caries directed access, when we discuss, dentin conservation techniques, and maybe what matters with the hierarchy of tooth structures, how does that all fit within the spectrum or the continuum of the endodontic restorative complex? Endodontics is very repetitive. However, every individual is completely different. And I think that goes across the board for all dentistry. I ended up choosing endodontics because I'm just a horrible multitasker. And when I practiced as a general dentist, it was just so hard for me to really zone in and focus on, one thing at a time with so many other aspects of the office going on. Then you couple that with owning an office and running that from the day-to-day business aspect, it was just very overwhelming. So I'm so thankful that I found endodontics. But when I'm discussing cases with patients, we have to be cognizant and mindful of the decision-making process. And, when I teach residents, I often tell them that it's not just about assessing the case, looking below the CEJ and trying to say, well, how can I get from point A to B? Because we oftentimes understand that it's not so linear. Point A, A does not always equal B. You don't always go A to B. Sometimes you go A to C. And so there's a lot of variation within dentistry, specifically within endodontics. And these are a lot of the factors that I consider before I even start my case. And again, I like to think with the end in mind, which means the restorative, and how is that going to work out for the patient in the long run. Like
Marcus,
I alluded to earlier. Yeah.
Marcus, there's a gray box on the top that kind of blocks part of your slides. Do you have a window open up where your cursor is there?
No.
Okay.
Is something blocking the presentation?
Just part of it. It's above the green line. There's a rectangular gray box that I thought might have been another window you had open.
No, that's the actual Zoom. Let me see if I can hide this.
All right. Don't, it moved.
Yeah,
now we have an additional gray box. Yeah.
Yeah, I'm afraid that if I close that, it may close me out of the actual Zoom.
Right. All right. It's not really interfering with too much of the slide, so just leave it. Thank you. Sorry.
Okay, I'll just put it off to the side there. Let me see if I can, maybe I can hide that. Let me see.
That's worse.
There we go. Okay, so that works.
Now it's in the middle. Okay, but now can you raise it up because it's in the middle of the screen now? There we go. It's gone. Whatever you did. Perfect.
Perfect. All right.
Sorry.
As I alluded to, I will be speaking from a standpoint also from perspective of new files and new, characteristics that allow these files to help us conserve them. And like I mentioned, Colting, they have been very supportive of me and my practice since I was a resident, and I'm so thankful that we continued that relationship. And for 2022, I actually made it a point that my new word would be partnerships. I'm not actually, I don't always make resolutions, but partnerships is what I'm after. And so this has been a really great partnership. So I will be mentioning a few items that I use. Again, this is not a sales pitch. It's just essentially saying that I want to show you transparency in how I practice. And if these are if this is the armamentarium that I use to get me there, I want to be able to highlight that. But obviously, when we are using files, we want to be very aware to avoid perforations, canal transportations, fractures, of course, disarticulations, and the last one, unnecessary removal of tooth structure, okay? And we're going to talk about some new file innovations, but not too much. But I think that if you are doing endodontics, and you really should be doing endodontics, it's just a great time to practice the art and science of saving teeth. We see that there are so many new advances within files, whether it's regressive taper, smaller diameter, controlled memory, increased flexibility, resistance to fracture, things of this nature, which really allow us to maintain the natural shape or the natural anatomy of the tooth, but also to remove less of the pericervical dentin. And we'll get into that and kind of discuss and dissect the hierarchy of tooth materials and how we go about assessing that. So again, this is my basic armamentarium, just some of the files that I use. I use no more than about 2 to 3 files on every case. And any case that I'm highlighting this evening, I have completed with the HiFlex system. It's pretty much been my go-to. But I liken it to say that if Tom Brady plays for any team, he's still going to perform at a high level. So if I use a Pro Taper file, if I use Brasseler, what have you, I still perform at a high level, but I've just found a strong level of confidence with the HiFlex EDM system. So, root canal saves teeth, right? That's the question, at least. I have so many patients that come into my office and say, you know what, doc, I came here because the recommendation was to see you, but I've had root canal in the past and it just does not work. And those are the individuals that we really want to save because they've had a disheartening experience for whatever reason. They feel that maybe root canals don't work. It could be a host of a plethora of reasons. Maybe the endodontist is not completed to a certain standard of care or standard of practice, you will, or possibly that there was some missed anatomy, file separations, complexity, you know, just a whole host of different reasons as to why the tooth may not have worked. So I just kind of want to give you an overview of a case that I had that really set me upon my path and my journey into becoming what I define myself as a restorative endodontist. So this would seem to be more or less a basic case. And I should add this as a caveat. I completely stay away from using that word, basic. Oh, this is straightforward. No, I say there may be a certain level of predictability here. However, easy, basic, I throw those out. They're no longer in my vocabulary. However, at the time, that's how I assessed this case. Patient came in, had some deep decay that was excavated by the general dentist. They felt they were close to the pulp horn. You can see here on the mesial aspect. So they referred the case. More or less, I evaluated. They were starting to exhibit symptoms of symptomatic irreversible pulpitis. So we indicated that root canal was going to be the best option for this patient. Completed the endodontics to what I would say was, you know, a standard of practice that's acceptable. You'll look at my access then versus now, but more or less I was able to manage the anatomy, fill and shape the canals, and send the patient on his way to go get a restoration by the general dentist. Was in pursuit of my board certification, so I really got into the habit of recalling cases. Recalled this gentleman back, and within a year, we already see that there is some furcation involvement, periapical lesion down here in the apical region, a lot of resorption. So I was very concerned as to see what is really going on here. Why would this tooth fail? I double checked all my notes. I wanted to really see was there maybe any missed anatomy I could have overlooked. So I was just really pondering myself, and I just couldn't figure out why this case was failing. Took a CBCT. Thankfully, I was now practicing with the cone beam in my practice. And you may or may not be able to appreciate this. Hope you can see my cursor. But this right here represents communication between the distal aspect or the mesial aspect of the distal root, okay? Within the endodontic literature, for quoting Albaraz, who's actually a prosthodontist, but we call that the danger zone within that furcation region. So almost the most distal aspect of the mesial canal, mesial root, and the most mesial aspect of the distal root. So this right here really represents a strip perforation. Essentially, that tooth that was eroded. There was communication. Next thing you know, this young patient had to take his tooth out. So I took that very hard, and I started to contemplate how that happened, how that occurred. I spoke to the general dentist, and we came to the conclusion that possibly maybe I could have over-prepared the canal, but at the end of the day, she placed a post, and during that post placement, there was a strip perforation that occurred. So when we assess a tooth from this standpoint, I started to question, what is a post really used for? Is a post really necessary in this case? And what could I have done differently to prevent this from happening? So just keep that in mind as we move through the presentation. Another case. Patient comes in, tooth number 31, extreme pain. I mean, we're so close to the IAN, you know, the guy was just hysterical. Hey, doc, you got to get me out of pain. This is killing me. Love documenting my cases under isolation. You can see just the gross caries direct into the pulp chamber. At that time, I was very comfortable practicing and completing the root canal. and sending those back for restoration by the general dentist. As you can see here, place some, I think at that time I maybe used a little cotton, and then of course I used a dual temp, which is it's a dual temp is a semi-permanent restoration that you can actually cure as the patient leaves the office, so therefore it kind of sets. Like I mentioned, it was an extremely hot tooth, so I had to use my intraosseous technique to get the patient fully anesthetized to achieve full pulpal anesthesia, and I'll touch on that technique a little bit later. But essentially, I love the recalls. Patient came back, and now I see this. So we went from what you see here, which was pretty bad, gross decay, to now we can see gingival overgrowth into that space. There is no restoration there, and this patient is not going to be able to retain that tooth. In addition, somehow tooth number 30 was in just as bad a shape. So now this patient is out 2 posterior teeth that are essential for function and form, and he was a young guy. When I say young, definitely under 40, maybe third decade, 35 or so. So these 2 cases really kind of got my brain stirring about what I could do differently and how I could change how I practice and what conversations maybe I could have with other dentists so that we could better prevent against these sort of presentations in the clinic. So I started doing some, some digging and just talking to other individuals, specifically a lot of individuals on TDO. It's more or less a dental software, but it's more geared towards endodontists. And I came across a lot of guys who were actually so passionate, and women, passionate about restoring the tooth as a continuum of the endodontic care. And if you know anything about endodontics, when I mention the name Rick Schwartz, you know that when there comes to any sort of royalty within endodontics, he definitely fits that. He fits that profile. And he once was quoted as saying that at the tomb of the dead endodontist is a sign that reads, "The tooth is not restored. The endodontics is not complete until the tooth is restored." And so he is one of the pioneers, if we were to maybe give this a term of restorative endodontics or, dentin-directed sort of access designs. John Cotomy, Marguerite, a lot of names that when you speak, they're going to resonate within our community. And so I said, you know what? Let me start having these conversations with general dentists or those who refer to me and see how they feel about me restoring the case, especially since I'm already under isolation and I can really see what's going on with the microscope. As you can see, there was a middle mesial. There was three canals in the mesial root. And I have direct access and vision to restoring that tooth so that hopefully those patients do not lose their teeth and once they get lost in translation, because we oftentimes know that once the patient is out of pain, they tend not to return as readily to the general dentist. So that's the journey I'm going to kind of take you on. I just wanted to give you a brief overview, but of course I had to develop a application of techniques and principles and have a systematic approach, and we'll get into all that, but I'm not going to beat you guys over the head with this because you are all practicing at a very high level, I'm sure. I'm just kind of sharing what has worked for me, and if there's anyone out there, maybe this will work for them as well. Of course, we have to start with some very simple basics. You must have a pulpal and periapical diagnosis. If you're not familiar with this, this is a great time to just take a quick snapshot. When I teach residents at Interfaith and I have them make a case presentation, they come up to me and say, well, doc, here's the diagnosis, bombed out tooth, gross caries. I say, you know what? Stop right there. Let's reevaluate. Those are great descriptors. Those kind of highlight what's going on within the dentition, but they do not actually define diagnosis as defined by the American Association Endodontic Glossary of terms. And so it's very important, since we are scientists, that we communicate as such so that we can relay exactly what is going on at that time to help better facilitate proper treatment of these sort of cases. So pulpal diagnosis and periapical diagnosis. And we recently had updated those, probably I think it was 2012 and then maybe even again in 2017. But it's always nice to just be familiar with the endodontic diagnosis. This is just basic exams and procedures. Most of you are very familiar with that. It's just always nice to kind of touch up on this. just to see there's so many different adjuncts that we can use to really help us get to a proper diagnosis. Endo ice, I put this in there because I'm going to highlight a study where we were trying to find predictors of profound anesthesia and really trying to dictate where the inferior alveolar nerve block has failed so that we can better assess when a patient is profoundly numb versus when they're just experiencing soft tissue anesthesia. Because the hallmark of endodontics is we are the specialists in managing pain. So if we cannot properly and thoroughly, fully anesthetize a patient, we're already done before we've gotten started. These are just some of the modalities I use to assess vitality. Anytime before I start a case, I always will go back with the endo ice, and that's also a coating product. Just happens to be not promoting that, but it's something that I use. Probably most of you are familiar with that. Electric pulp test, perioral probing, and of course the test cavity, which is the gold standard. And if you ever drop into a tooth and some patient screams, it's not the most pleasant experience for you or them, but it definitely lets you know that that patient is not numb. So I love cases. And in residency, we were nerds, and you know, it was kind of cool. I was in Cleveland, Ohio. There wasn't too much going on. So every now and then when we did good in resident review, our director would give us tickets to go see the Cleveland Cavaliers. At the time, LeBron James was there. So we were all about, you know, just learning and studying endo from sun up to sundown. So this is a case where we say the patient, we put the quotes around exactly how they stated. My tooth has been painful and hurts me when I bite. History of trauma 2 years prior. Extra old examination. All of you know WNL stands for we never looked. You know, I wish it was a little bit more interactive, but it's a little bit different speaking to a computer, but nonetheless, a little humor for you there. And look at this, no response to endo ice or EPT. So just based on this, we should already be able to formulate a diagnosis based just on that. I'm not going to belabor the point, but most of you are probably thinking with some sort of necrosis, and we can see that's the case. However, there is something that is of major importance that is missing from this diagram, from this photo, and this is just to make a quick point. There is no rubber dam clamp on this tooth. Now, obviously, oftentimes I ligate teeth with wedges or some sort of floss to get good isolation, but essentially, I still get a lot of cases flowing through my practice. When I place the clamp on the tooth of the patient, they say, "Oh, doc, what's going on? What is this?" I say, "This is a rubber dam. This is pretty much a standard of practice. This is going to help isolate the case." I've never seen that before, but they have 3 and 4 root canals. So as long as their practice is still out there, I guess we'll keep thriving. But we like to make a change for the sake of the patient. So I always love to just kind of show how I practice. This is just very basic. You may do a different approach in how you actually manage your cases and place the rubber dam. This is just a patient. I always place a cotton roll because I kind of have big hands when I'm working. I oftentimes can push on the bottom lip and it kind of can go into the incisors and kind of painful to the patient. I love this rubber dam because it's all one unit. And it's very flexible if I need to stop and take intraoral radiographs. And I love using the, using that without having to really make too much adjustment to how I practice. Go ahead and get isolation. Rubber dam over the wings, as you can see there. Just kind of let that play out. Ligate with the widget, snip, snip. And just like that, I'm pretty much ready to start practicing. Sometimes I'll even get more isolation by playing like a flowable on the sides here, or some sort of barrier just to protect gingiva, the saliva from creeping in there as well, and also to prevent any sort of leakage from my irrigation. And we'll touch on that a little bit later, but just the point of a few things I do. One of the best things about endodontic residency was I finally was able to develop my own systematic approach to how I complete endo. Obviously, this has shifted tremendously over the years. But it was just very nice to have a systematic approach. And I used to pretty much have literature to support each and every step along the way, as was the requirement for endodontics, endodontic residency. But it's really nice to be able to have that. So that was prior, that was 2011. And now you can see I've significantly changed that. And let me just highlight one of the biggest changes for me. Let me see. Identify points of negotiation from the chamber, okay? And we're gonna talk about that. When we have a concept of what individuals like to say, straight line access, that's just it, it's a thought, it's not necessarily a rule. So we're understanding that with new metallurgical advances, we do not have to always achieve straight line access, but we can still properly clean and shape the canals and keep the anatomy in check. So as I alluded to earlier, the endodontists, we are the specialists in managing pain, not just saving natural teeth. So I did just want to take a few points to highlight a few cases and a few studies that I think are very important. I just was able, I host a podcast for the American Association of Endodontists. Any platform you have, whether it's Apple, Stitcher, Spotify, Apple Music, what have you, you can listen to it. It's called Endo Voices. And I had the pleasure of speaking with one of the foremost experts on pain, Dr. Ken Hargraves out of San Antonio, UT San Antonio. And it just blew my mind. His depth of knowledge is inspiring. And so if you ever have time, you want to listen to something on your drive in, or if you're just doing chores around the house, I encourage you to tap into that. And he really just breaks down the whole spectrum of pain, specifically odontogenic pain and non-ogenic sources as well. But in order for us to do quality endodontics and quality restorative, we must be able to properly manage the pain. So just a few distinctions. Relief from pain is analgesia, and anesthesia is loss of sensation. Okay. And I just highlight this because on any given day, as most of you know, not just endodontists, we deal with patients with high anxiety. They're coming in a catastrophic state, and we understand how that affects pain. As anxiety goes up, the pain threshold goes down. So really just understanding that and looking at other factors, age, phenotype, ethnicity, the ambiance, gender. So all of those do have some sort of value, and I'm going to highlight a few studies on predictive values and really assessing pain. Here are just a few risk factors. We already kind of touched on genetics and that importance, and obviously gender as well. Nitrous oxide, I'm so thankful that I was able to introduce that into my practice, in addition to oral sedation as well. I do work with a trained general anesthesiologist. He's actually a pediatric dentist who is trained as a dental anesthesiologist. And at least probably once or twice a month, we'll have some sort of case on a Saturday and bring in a patient, and it needs to be intubated or what have you. And it's really just allowed my practice to flourish because we're able to provide another way to save teeth and keeping the patient outcome at the forefront. So nitrous is something I use quite often as well, but we understand that it really doesn't have too much of an analgesic effect. It's very limited. And if we look at classic studies, we understand that the success rate of the inferior alveolar was 50% for the nitrous oxide group and 28% for placebo. This is a classic study. However, it doesn't provide just a significant analgesic effect, but it is a good adjunct to calm anxiety, but you still must have a good technique to get the patient done. So this was a study out of Costa Rica. And what was interesting is it was a cross-sectional study. And what they wanted to find out was different predictive values on really evaluating accuracy in testing of how numb patients are. So they're essentially looking at 3 different ways to test or to assess the level of pulpal anesthesia, okay? One thing I should point out in this study, they actually used mepivacaine 2%. Yes, that is actually what they used. I guess that must be something that's popular within Costa Rica and Mexico. But nonetheless, that's what they used for this study. The 3 different tests that they used to assess was lip numbness, and they looked at 3 different points on the lip, and they would kind of squeeze it with the tweezer. Cold, obviously, with endo ice, testing the buccal surface as well as the occlusal surface, and then comparing that against contralateral teeth. And then responsiveness upon access, meaning if they're removing any sort of decay, old restorations, is the patient agitated, are they sensitive? And then, of course, the gold standard is once you're actually into the pulp chamber, how is the patient responding? So they were pretty thorough, and they had a decent sample size. So let's kind of see what they found out. Lip numbness, a third of the time, was actually significant in showing that a patient was numb, or actually showing, if you will, the other way, 60% of the time that the tooth was not fully anesthetized. Okay, so showing that the inferior alveolar nerve block was actually failed. Now, one of the issues with this study was they only used 1 cartridge of mepivacaine, and of course they were residents, but they were using a visual analog scale that was introduced to the patients prior to any treatment, and then they were kind of assessing that along the way. So just a few caveats. And cold test, which I still use on a day-to-day basis, it's not 100%, but you can see about half the time there was some sort of level of accuracy there. And then, of course, responsiveness during access. And the gold standard, of course, was manipulation of the pulp tissue. So essentially from that, they found that there was really no test that demonstrated a high enough accuracy to be considered a reliable diagnostic tool for the prediction of anesthetic failure. So what does that mean? That means that we have to look for alternative ways, supplements, possibly using NSAIDs preoperatively, using any sort of adjuncts, maybe buccal infiltration, intraosseous, things of this nature to ensure profound pulpal anesthesia. And when we look at literature from Ohio State, our readers group, Melissa Drum and those individuals, we know that from their studies, it usually takes a good 15 to 18 minutes to achieve profound pulpal anesthesia. So just keeping that in mind and understanding when patients come in, oftentimes to my practice, they're in a heightened state. So you have the upregulation of the TTRX and things of this nature, and the prostaglandin production is very high. So there's a lot of concern within the patient, which in turn means they have higher anxiety, which sometimes means it is a little bit more of a challenge to get them profoundly numb. And we can see that from this study that those are not the most reliable ways to assess how numb a patient is. So like I mentioned, sometimes a supplemental intraosseous injection is going to be the best, 4% articaine followed by supplemental buccal and lingual infiltrations. This was another study that they kind of looked at a systematic review as to what were the best techniques to achieve pulpal anesthesia in patients with symptomatic irreversible pulpitis. And like I alluded to, preoperative NSAIDs or sometimes opioids with or without acetaminophen may increase the efficacy of these injections. And like I mentioned, Ken Hargraves really breaks down the exact science and how that works. And if you get a chance, again, that's Endo Voices. I would encourage everyone to just download that, and you'll learn a lot. It's really interesting. I'm not going to say too much on this. We've already kind of highlighted that there are differences within gender, but according to that study, they saw that women were 3.8 times more likely to develop chronic pain after root canal. We're not going to speak too much on chronic pain, but that was just a highlight from that. And this right here, yes, this is classic. Being able to establish a rapport with your patient is pretty much everything. And we can go as far back as 1964. And we understand that this to be true, that pre-op discussions of surgical treatments and associated discomfort reduced by 50% the need for post-op morphine and reduced the time to discharge. I have seen that phenomenon. When a patient is fully engaged and they understand everything that I'm explaining, their post-op experience tends to be less stormy. So there's a lot to be said for the human element and the humanity that comes into our practices as well. This was pretty interesting. This was just a random survey of a descriptive cross-sectional survey of AAE members. This dates back to 2006. I just brought this into the presentation. My chairman at the time was discussing this. And what we found is that the preference for endodontists specifically is we do not want to use narcotics. And we are going to use NSAIDs if we can over narcotics. And I think that should be true for all of us. We all understand the significance and the weight of the opioid pandemic and the crisis. And, you know, considering that we have also seen, according to the American Dental Association, I believe in March, they published a survey that we've also seen an increase in cracked teeth throughout the pandemic. 2/3 of dentists report seeing an increase in patients coming in with cracked teeth. That means more pain. Sometimes we're overprescribing narcotics, things of this nature. Individuals can't get into the dental office, the pent-up demand. So just always be very cognizant and understand that the literature highly supports that the best combination for dental pain, specifically odontogenic pain, is NSAIDs in combination with what we call acetaminophen, and that flexible prescribing pattern is really where the value is for the patient. And just so from that survey, it was statistically significant that 600 milligrams of ibuprofen given 4 times a day was the preferred analgesic that the endodontists were prescribing. And I think that that is very true to this day. Like I said, Ken Hargraves really outlined the best combination. And we see that it is usually some sort of mix of the ibuprofen and Tylenol, because we understand there's going to be the central effect as well as at the higher level. So just to kind of keep that in mind. I'm not going to speak too much on this. I want to move along. But this is just something I put in there about Vicodin as to why we still prescribe narcotics. Sometimes it's to manage patient expectations, to ensure satisfaction, fear of bad reviews, which is very real, especially as we move towards a more value-based, reimbursement system. Insurance really looking to reimburse dentists based upon patient experiences and then actually sending the check. So, there's a lot of reasons as to why we may prescribe and end up over-prescribing, but just want to put a point out there that since we are talking about pain, it's important that I at least highlight the importance of sticking with NSAIDs and acetaminophen over narcotics. So this was encouraging. This was from the New England Journal of Medicine in 2019. But we saw that, there were half a million fewer opioid prescriptions over a 5-year period. So we actually were prescribing less in 2017 and 2012. I have not checked the trends on that lately, but hopefully the word is out and we are actually moving forward in a more judicious manner and a more responsible one to actually help, put a pause on that pandemic of the opioid crisis. Of course, I would be remiss if I were not to bring up classic literature from NYU. And, NYU is where I learned so much. And like I mentioned, Dr. Weiner is on the call. And he was one of my clinical faculty. And we probably did our first root canal together. That must have been back in 2007. Kind of dating you there, Doc. But nonetheless, I also learned a great deal from Paul Rosenberg, who was the chair at that time. And this is his classic study, trying to evaluate the effect of occlusal reduction on pain after endodontic instrumentation. So they had 117 subjects that were in need of root canal. They recorded all of the vitals, the pulp vitality, pain upon percussion, presence of perioapical lesions, things of that matter. And what they were trying to assess was what was the best way to control postoperative pain, or what were the predictors of severe postoperative pain, and how can we control for that? In conclusion, they developed that occlusal reduction should prevent postoperative pain when a patient's tooth exhibits their pulp vitality, so essentially symptomatic irreversible pulpitis, percussion sensitivity, preoperative pain, and absence of the periapical lesion. Surprisingly, a lot of us would think that the presence of a periapical lesion would indicate that you have more discomfort, but according to this study, that was not the case. And so I highlight this because occlusal reduction is a big part of my practice. But when we're actually talking about the restorative aspect of dentistry, we want to be mindful of occlusion, and things like the Bull rule maybe do come into play at some point. So occlusal reduction is always something to have on deck, but we always want to be mindful of occlusion as well when restoring those cases. This is just a slide if you want to just take these are the most commonly prescribed combinations, and I just thought it was pretty good to have. This is from the Colleagues of Excellence 2015. It's a newsletter that most of you receive, and I actually authored the Colleagues for Excellence on antibiotic prescribing within endodontics. So if anyone wants to kind of review that, you can get that online from the AAE. So this is just something I was going to speak on, but based on time, I'm going to kind of breeze through, the anesthetic techniques. I really just wanted to highlight something that has significantly transformed my practice, which is the intraosseous technique. But I will just take a moment to show you just a schematic of the different locations for different techniques to get the inferior alveolar nerve block complete. So you can just see the different locations. I still have hesitation with the Gal gates. I never actually brought that into my treatment armamentarium, so to speak. But I do know a few clinicians that swear by it. And as long as it works in their hands, that's really all that matters. So the intraosseous anesthesia, I happen to use the X-tip, and I'm just going to break that down for those of you who may or may not be familiar. I've seen that oftentimes when patients come in with a hot tooth, I've tried PDL, I've tried an mandibular block, they were on NSAIDs prior to the visit, you name it, we tried it, but this has really been a significant shift in my practice in terms of getting profound anesthesia in a consistent manner. And so you can just see how it is. It's kind of coming as a drill and a guide sleeve. And what you're going to do is when you actually pierce through that cortical plate into the cancellous bone, is you'll actually remove that sleeve, and then you can put your needle in, usually with 2% lidocaine is fine, and actually achieve very profound pulpal anesthesia. So this is just a diagram of me showing that technique. Ideally, you want to place that distally to the tooth in question. In case the patient had a hot tooth, number 19. Obviously, there are some exceptions. The maxillary, second molar, sometimes that bone is so thick, it's very hard to pierce through, so you could actually burn or erode some of the bone there, as well as the gingiva, and they're going to have a very uncomfortable post-operative recovery. And in those situations, a mesial site is fine, but it's not as effective if you were to go distally. There are a few contraindications. Inject into a periodontal pocket, lack of interproximal space, and in fear of you may gouge any roots when you're trying to actually penetrate into the bone. So those are just a few considerations. As you can see here, I actually didn't even put it too far into the alveolar bone, but nonetheless, just by sheer mechanism, you can still achieve very good pulpal anesthesia. And you can see just a little study from Newstein. Again, that's the group out of Ohio State. And I mentioned Ohio State because that was our rival, meeting at Case Western, which is in Cleveland. They were at, the Ohio State. And it was just interesting to see they put out so much literature regarding anesthetics, and that's pretty much what they're known for. So if you ever want to have any author to quote, you can never go wrong with Al Reeder, Melissa Drum, John Newstein, when it comes to anesthetic studies. So that's pretty much the significance there. So the injection site is 3 to 7 millimeters apical to the mucogingival junction of the mandibular molar. So you can see that schema right there. And you're going to get up to about an 82% success, but it is highly technique sensitive. And since I've not perfected, but since I've improved upon my technique after about 30 or so cases, I guess is when you can say that you're very comfortable. I'm usually at right around 95. I rarely have a case that I cannot complete with profound profound anesthesia after using the intraosseous technique. Obviously, the transient heart rate will be repeated a little bit more. Okay, 2% lidocaine is fine, although you can use lidocaine 3% as well. You don't have to use anything with lidocaine. It's still going to have effect because it's actually penetrating into the cancellous bone, so you don't have to worry about that. Some issues that may occur, like I said, slow healing on the gums if you burn or kind of burn through that bone. That can be a problem with the perforation. You can overheat the tissue there. So just want to give you that overview just to let you know kind of how my journey had started and where I'm at now. So just to bring you back and recenter you, restorative driven endodontics started to become a thought in the back of my head after this case and after a multitude of these cases. And I kept seeing them come through my office, and I was very discouraged because that reflects on me as, man, is there something that I could do to change that outcome? And so I really decided to take that and commit to that. And I think that it's benefited me. I've lost some referrals along the way, but at the end of the day, I think we take a consensus. It's all about what's best for the patient. And so we're going to go ahead and just kind of discuss the idea of restorability. So when we talk about cuspal coverage, and whenever someone refers a case to me, I always say, prognosis, diagnosis, prognosis, and I'll give a recommendation. Recommendation may be as involved as, you know what, if you could restore this with an alloy. I still use amalgam in my practice because I feel that when difficulty with isolation happens, my posterior teeth and aesthetics are maybe not as much a concern. It's a little bit more forgiving to the gingiva. I feel that it still has a place. Now, I can't say that many people agree with me, but I think there still is some value. So I'll sometimes make those recommendations in my reports. But this is what's really important to me right here is that we understand that posterior teeth that are intact, except for the access cavity, can be restored successfully with composite linking. And I think the literature is replete in showing that. And so when we go back to the case where I was highlighting, I was always questioning, is a post really needed in this case? What was the value of placing that post? And we could make an argument either way, but we could also say that maybe, possibly, this patient would still have their tooth if a post was in place, or perhaps the person who's most familiar with the canal can place that post space and then maybe send it back for the post to be restored, or actually place the post themselves. So just looking at different ways to analyze a case for the best outcomes of the patient. Posts do not reinforce endodontically treated teeth. Their purpose is to retain the core rather than reinforce the root. That was old thinking. That still holds true, but we understand that sometimes in anterior teeth, we can actually reinforce those endodontically treated teeth if they've snapped off at the CEJ and we're trying to restore that, some sort of deep margins, and we have to maybe elevate that margin and create a little bit more of a, I guess, robust ferrule, if you will. Crown lengthening comes into those considerations as well. But what I'm saying is that we have to kind of think outside of the box, and it's not always, there's really no law about restoring teeth. And so once you start to get a little bit creative, I'll show you some of the things that many of these endodontists on TDO and other platforms, what we're trying to do in terms of saving natural teeth. And we're getting very creative with the new file systems and some of the technology that's available. And Of course, the golden rule, a post is recommended if insufficient tooth structure is available to hold the core. So that's key. Madison is actually an endodontist. Leaving 5 millimeters, usually I guess the rule would be 4 millimeters or so, but leaving enough to have that apical seal. But understanding that now, sometimes especially when it comes to cracked teeth, and we can pull from literature, most specifically Davis and Sharif in 2019, they had a study where they were actually looking at cracked teeth, and what they did was a new treatment protocol, obviously under isolation, where they would actually restore the tooth with bonded resin below the level of the crack, at least a few millimeters below the level of the crack, and they were getting very high outcomes, mid-90s, with 1 year and 2 year outcomes. Cracked tooth is always an enigma for endodontists as well as any practitioner. And so it's very hard to gauge how long those teeth can actually hold up, especially if a patient has parafunctional habits. But at the end of the day, we are finding new and creative ways to prolong the longevity of the cracked tooth, and understanding the value of post-placement and sometimes placing resin tags in substitution. That was just a mention of perioendo lesions. Again, we're always talking about a pulpal diagnosis and a periapical diagnosis. When it comes to the perioendodynamic, that whole spectrum, ideally, we want to treat the closed system first, but we understand that there is a communication sometimes with a concomitant, but I just threw that in there just as a reminder. So here was a case, and I was really evaluating if this case was restorable. Patient came in, was very adamant about saving his tooth, had just flew in from London, and said, "Hey doc, I got a big abscess." He didn't actually use that term. He said, "I have a big pimple on the side of my tooth. I would love to save my tooth. Let me know what's going on." So went ahead and assessed the case. You can see here I was able to kind of trace right along communication on the buccal aspect, just kind of went through the gingiva. You can definitely see that the gutta percha traces through the furcation region. So I already told them that it was a little bit of a questionable prognosis if we would be able to restore the tooth. If you understand that this was a symptomatic case, we're now thinking that it's more periodontal in nature, okay, or some sort of crack or fracture. And so he was in a lot of pain, but he obviously had this gingival abscess. So I was able to get my working length, place calcium hydroxide. I still love calcium hydroxide. That's up for debate. I believe it was introduced into the literature around 1920. A gentleman named Herman actually kind of brought that to our knowledge. And we love it because of the hygroscopic nature. It's going to dry out canals. Obviously, the high alkalinity. It's going to be an antimicrobial. Lots of different factors. And so I wanted to use it to really just give this tooth the best chance of success. Of course, I could see that the crack extended down onto the furcation, onto the pulpal floor. So we were already anticipating that, hey, this prognosis is trending downward, because we understand the literature. Once you kind of get into that critical zone, those do tend to propagate over time. Nonetheless, we wanted to go ahead and move forward and save the tooth. And when he came back for his reevaluation, oh no, I'm draining it here. This is just, I like to do a vertical incision. Some people agree with that, some don't, but I like to go pretty much with the vasculature in that direction, change the redox potential. We're dealing with anaerobic bacteria, sometimes strict anaerobic, and so just getting in there and changing that's going to be effective. But what I wanted to highlight was see what's going on right here, and that's going to come into play in the next video. Just kind of take a look in that area, what's going on. So I was able to get him some relief. Like I showed you, I had placed calcium hydroxide, went ahead and just drained the abscess just to help him out and really make sure that he didn't have any sort of issues postoperatively. Came back for his evaluation 2 to 3 weeks later. Yeah, that's definitely a goner. And so, you know, we tried, and it wasn't too much of a heartbreak, but nonetheless, we were both sad. And I started to evaluate again. What maybe could I have done differently to help save this tooth from, you know, this disastrous outcome? And of course, I forgot the golden rule from Paul Rosenberg and Schertzer, Leong, and Babick, occlusal reduction. So what I'm saying is that, you know, like my father mentioned, the biggest room is the room for improvement. And so as I kept seeing cases come through and I really started to think about the restorative, now I was finally starting to think with the restorative aspect in mind first, as opposed to having that myopic view of just looking at the endodontics. Here's another case before I actually had that epiphany. Patient came in, cracked tooth number 30. Referring practitioner wanted me to just kind of leave a post space, did the root canal, had a couple puffs, little macrophage feast here and there, but keep in mind, during residency, they used to call me Puff Daddy because I was known for having these sealer puffs, and we understand that there really is no significant difference in outcomes with that, but nonetheless, I did have my puffs there, and I felt pretty good. Patient was okay. Sent her back, and the doc called me and said, "Hey, Johnson, nice root canal, but I can see a crack line in your temporary restoration." I said, "Oh, are you kidding?" So I said, that I don't see that quite often. Send her over, let me see what's going on. Lo and behold, split tooth, you can clearly see that. So again, I was starting to think, was there anything I could have done differently to maybe prevent this outcome? I'm not sure, but maybe if I would have placed it a bonded core, who knows? So bottom line, I was thinking along those lines. Without a doubt, you can see that the lingual aspect is mobile. This tooth has to go. It's a cash paying patient. And we're not going to have a real discussion about value, but nonetheless, I wanted to keep my integrity for the sake of the patient and also honor the referral. So we worked out something that was fair, and we were both, both equally happy. But when it comes to those sort of situations and finances do come into play, you know, it's rarely an issue for me because I'm just so blessed to be able to practice, just to be in my position. I've never been highly motivated by money whatsoever. It's just sometimes needed for a value that I'm providing in exchange for services. But by all means, I'm always happy to work with the patient and make sure that the value that they expect, they receive that if something like this would occur in an untimely fashion. So this is probably a good place for us to maybe take a quick 5-minute break before we really get into the heavy restorative aspect and discussions about restorative endodontics and what does that really mean, and looking at the hierarchy of tooth needs. So if there's any questions in the meantime, I'm not sure how I can actually see if there are, but maybe Eugene, you can help facilitate if there were any questions.
Yeah, if they type the question in chat, I'll read it to you.
Okay. So
right now there are no questions in there, but
no problem. So if everyone is fine, I have no problem continuing. Or if you want a few minutes break,
I think you can move forward.
Okay. Sounds. So you know, I'm a funny guy sometimes, and I always have funny experiences practicing in New York City. And I have no problem making fun of myself. One of the top questions that I was asked as an New York City endodontist was this, most recently, because the Knicks are playing very well. Do you play for the Knicks? I get it. I try to keep myself in shape, so I do kind of have a more athletic build. I'm tall, and, you know, I'm a black guy. So just to be facetious and have a little fun, this is me. I had season tickets to the Knicks, and I really got to enjoy that experience. I knew a lot of the guys, and I'm hanging out in the locker room here. So just to be clear, this is Dr. Johnson, the dentist and rec league ball player, but oftentimes People would think that I was Justin Holiday, former Knicks player, really cool guy. I actually have him on the text. And sometimes it was good. Hey, man, there's a party over here. You want to come hang out? We're getting dinner. It's all comp. The owner's happy. And when the Knicks were losing, you know, I'm ducking into the office. Tomatoes are getting thrown at me and such. And so it's been a whirlwind experience. I love what I do and love practicing, and being able to kind of come across individuals like this as part of being a dentist is a lot of fun. So just want to kind of highlight that to lighten the atmosphere a little bit. Paradigm shift, modern endo, access and dentin conservation. What you're looking at is, on a day-to-day basis, my armamentarium. I have completely done away with any round burrs. I only use tapered diamonds, sometimes fine tip metal burrs and access. You can see I have my ultrasonic tips as well. You can see I have a bend in what we call a controlled memory file, which allows me to really keep a lot of dentin intact and still get into the canal system. And this is a case that I'll highlight a little bit later. Some of you may or may not be familiar with this, but this case presented to my office. General dentist had recently done a nice restorative, occlusal restoration. Patient became symptomatic relatively soon after. You can see that they are missing some occlusion mesially. And so I was thinking, this is a very wide pulp chamber. What's the best way that I can conserve dentin and still address this patient's chief complaint? And so this is a very popular access, what we call maybe a dual access or a truss access, because we're keeping the truss intact, which is really going to help resist against fracture. The literature is not 100% in terms of what we call conservative endodontic access versus traditional in terms of long-term outcome. But nonetheless, if we can go ahead and employ a technique like this and our cleaning and shaping is not hindered, I like to think that it does provide some kind of benefit for the patient, because we understand that most teeth are going to fail due to structural failure. And then from there, you're going to get some sort of recontamination of that space. So if we can do anything to prevent against structural failure, why not? A full coverage restoration is still recommended, but nonetheless, now having that truss intact, you can see I was able to get into the dentinal bridge there, the furcational bridge, clean that space out, obviously with the ultrasonic, and I think I'll show a video of how I was able to compensate for that. So minimal engagement endodontics, or more popularly, minimally invasive endodontics, okay? And so what are some of the advances? What are some of the trends that have allowed us to even begin to coin these terms? Because everything starts as a thought. And so if we can actually have a thought and then coin a thought, then it's kind of relatable. And now we can actually use this to develop not just a trend, but an actual practice of dentistry. And so that's what we've kind of seen. And so we've seen new developments and innovations in magnification and imaging. I think I'll show some photos of me working through the microscope. CBCT is an everyday staple within my practice. I don't use that on every patient. We have a American Association of Endodontics position statement where there are certain cases, maybe like retreatment or challenging anatomy, where it is indicated, but it's not indicated for every case. However, the value in using it on every case can definitely be realized. So I tend to use that more often than not. And when we talk about radiation safety and, exposure, I just completed a podcast. When was it? Just, I guess, a couple weeks ago. And I was engaged in a conversation regarding radiation safety. And when we really look at the studies, there are no studies that show organ damage or sort of any tissue damage below 100 millisieverts. And when we think about cone beam CBCT, understand that cone beam CBCT at best, let's say at most, 30, 50 microsieverts. So we're saying that the literature does not support any major risk below 100 millisieverts, and it takes 1,000 microsieverts to equal 1 millisievert. So again, you can understand that when patients have a concern over radiation, they're more likely to have more exposure flying from here to Denver, or just even living in Denver, you're going to have more exposure. And then, of course, when we factor in background radiation. So it's really a good episode. I would encourage anyone just to tap in if you haven't. And it's just really valuable information that you can bring to your patients from a safety standpoint, and also safety for the dental routine. Image-guided treatment. So we're still using CBCT, but this is almost like dynamic guidance. So imagine that you're actually drilling your access while watching on a monitor. And so in real time, you know exactly where to drill and where to actually access the tooth for maximum dentin conservation. So these are some of the new technologies that we're also seeing. Patients' desire to save their natural dentition. We see a large shift towards veganism. Patients being, health is on the forefront. Minimalism. So patients really want to save their teeth. They don't really always want to opt for an implant. Although implants are a viable option when the natural tooth cannot be saved, we understand that patient desire must come into, is part of what's driving this shift as well. Placement of deep finish lines. When we talk about concepts of biologic width, this is not it is a concept, and we can't automatically just assume that 2.04, I think it is going to be ideal for every patient. Maybe some patient will be fine with just 1.5. Now, I know not everyone is going to agree with me on that. But what I'm saying is that we have to appreciate and respect the variation amongst individuals, therefore the variation that's going to exist within the dentition and the supporting tissues, soft and hard. Margin elevation. I think it's Pasquale discusses these sort of concepts, where we're not having to rely so much on crown lengthening, but by actually leaving the margin on the restorative material and being able to keep those margins more clean, that we're actually seeing long-term follow-up with some successful cases. Now, we're not saying that this works in every case. We still have to understand you still must respect biologic width to a certain extent. But what we're saying is that sometimes in certain cases, you can be a little bit more creative and actually see that teeth are going to be restored for a very long time. You don't have to worry about crown lengthening and now invading upon the furcation of the adjacent tooth and things of that nature. Key controlled files, controlled memory files, like I just highlighted in this slide previously. Innovations in irrigation, certain things like GenoWave or the BioLace, where we're now actually using multisonic irrigation to activate and remove debris from within the tooth, but also conserve the natural tooth and respect that anatomy, but still achieve the optimum goal of endodontics, which is to eliminate and treat apical periodontitis. So when you factor that in with different restorative materials and bioceramics, any host of the tricalcium silicates, we understand that we can now get more predictable seal of teeth as well. So when we are storing deep margins, and there are things that are in teeth that are being restored subgingivally, now with these new advances in materials, bioceramic materials, we can actually look to have predictable sealing ability as well. So there's a lot of different factors which are actually driving this shift of minimally invasive endodontics. And it's a very exciting time. And I tell you what, I come to work renewed and revitalized every day, anticipating on what new ways I can manage to save some of the natural tooth. Potential benefits of tooth structure. This is going to lead us into the next discussion of the hierarchy of tooth needs. Dentin loss, as we already discussed, is a main risk factor for fracture. Again, structural failure. If you look at conventional endodontic access versus traditional endodontic access, we can see that you're going to have around 30% less of that dentin removed when we kind of employ those conservative techniques and skills. Premolars the same, and of course molars, you can see that obviously with a conserved endodontic access, you're going to preserve more dentin. If you preserve more dentin, ideally you should be able to resist fracture, and if we can resist fracture, we can preserve those teeth for a much longer time. So this is more representative of the cases that I'm completing nowadays. If you remember when I highlighted my cases before, I really just was going for the straight line access. So I would make an access to meet right at the, negotiate the canal from the distal aspect of the tooth and from the mesial aspect. However, I can actually gain a conservative endodontic access and preserve the pericervical dentin to help resist against fracture. And with the new smaller diameter and regressive taper files, still clean in shape. And when we have different technologies to actually activate our irrigants and clean and shape these canals, we can actually have very good and predictable long-term outcomes and success cases for our patients. Here was a patient who came in, distal decay. You can see that, it's very clear, okay? There was a little bit of pulp canal obliteration, meaning calcification. You can't really make out the canals too much. So I was thinking what creative way I could manage this case. I love documentation, so I took a photo. You can see, obviously, there was a wide open cavity onto the distal portion of the tooth. And if I'm looking at the occlusal table, in 2011, I would have easily just disregarded all of this tooth. And we'll talk about, again, the hierarchy of tooth materials. Enamel is important, but not as important as dentin. But nonetheless, in order to get to the dentin below, I'm removing the enamel, and I would lose a lot of that tooth, right? So this was number 14, gross distal caries, SIP-SAP, symptomatic irreversible pulpitis, symptomatic apical periodontitis. So I'll be using SIP-SAP a lot for the rest of the presentation. Excavated decay, was able to clean out the tooth, and you can see I was able to get a clean margin. I'm still under isolation here, and you can see at least 3/4 of the tooth is still intact. Was able to go ahead and complete the endodontics. I still had a little puff here. Sometimes I'm still puff daddy. Able to manage a significant, dilaceration, and then go ahead and restore that tooth. And you can see at least now the patient leaves with some sort of substantial restoration. So in the event another pandemic happens, guess what? At least the tooth is now protected, or God forbid, they have to go travel for family emergency, what have you. Time goes by, and now that they're out of pain, they forget to get back to the general dentist to get the tooth restored. Recommendation is still full coverage restoration, but nonetheless, this is how I felt I could do my part in really helping to prevent catastrophic failure of teeth, at least from a structural and a microbial sort of failure aspect. Dennis went ahead and prepared the tooth. She just sent him back just to get a scan, just to make sure everything was clear before she cemented the crown. And she loved it. Hey, Johnson, I loved it. You sent the case back. Everything was clean. I'm not removing a lot of, cotton and it's getting caught everywhere. I'm not struggling trying to get that out. I'm not trying to re-clean the margin. It's already clean. It's shaped. You showed me with the photo how clean it is, so I can trust that everything is fine. And went ahead and took the scan. You can see all the anatomy was addressed, and now the patient is on their way to get the crown, and everyone is happy. So again, this doesn't work for everyone, but this is just something that I've decided to commit to as of late within the last 5 years. And I think that the trend amongst a lot of the endodontists that are coming out now is very similar, where we are putting a lot of emphasis on restoring the tooth. And keep in mind, endodontists only do so many root canals a year. Most of these cases are going to be completed by the general dentist. So these type of cases should be able to be managed by most general dentists as well, maybe not to the same level of the endodontist in terms of the endodontic treatment itself, but employing these same ideas in regards to tooth and dentin preservation. So when we talk about the hierarchy of tooth needs for posterior teeth, let's go ahead and designate what is high value, okay? pericervical dentin. I've alluded to this word previously. This was coined by John Cotomy, and we are looking at, he was an endodontist out in Durango, brilliant mind, and essentially what we're seeing is that 4 millimeters, I guess, above the alveolar crest and below, that is what we kind of classify as the critical region of the tooth to resist against fracture and breakdown. Now, obviously, sometimes if the alveolar crest is shifting, we're kind of more or less focusing on the CEJ for that pericervical dentin, but obviously we want to try to maintain as much of that dentin at the central neck of the tooth as possible. Axial wall, again, important for ferrule, we understand that, and cervical enamel. So if we go back to this case, occlusal enamel, yes, it's important, but if we're thinking about it, if we're actually cutting the crown, a lot of this occlusion will be reduced anyway. So they're still important, but the real importance in terms of enamel is going to be at the cervical region. So a lot of focus is on the cervical areas and pericervical dentin, as well as cervical enamel. And then we kind of go down here from medium and low. Let's see what low is. Tertiary dentin, all that dentin in response to inflammation, calcification. Tertiary dentin, excuse me, I think I said secondary. Tertiary dentin in response to inflamed pulp and, just necrotic teeth. There's really no value or no liability. So we can go ahead and excavate that at will. I'm not going to speak too much on this. I already mentioned John Cotomy. This was a paper that he put out with another author, Clark, and they really brought in a new paradigm shift with regards to how we view endodontics, and that is really an extension of the periodontics, because we understand, even from classic literature, Ray and Trope, and Dr. Wiener, I know you know this good classic literature, even though it was a retrospective study based on x-rays, what they were looking at was essentially 4 different groups. Good endo, it's just that simple. Good endo, was it within the standard of practice what they considered good endo, and good restoration, where the margin sealed, was everything intact, seemed to be fine, didn't invade biologic width, things of that nature. Then they looked at good endo, bad restoration, bad restoration, good endo, and then of course they both suck, bad endo and bad restoration. And so when you have good endo and good restoration, we understand you're going to have a very favorable outcome, 90s and above. And we saw that, however, when you have good endo and poor restoration, automatically that is going to significantly drop to almost well below 50%. So that just pretty much highlights how I started off the presentation. The foundational dichotomy of dentistry still exists, that the restorative is just as important as the endodontics when we look at the whole endodontic restorative spectrum. Here's a case of a cracked tooth, okay? And I wish I had a little bit more follow-ups on some of these cases. These are cases that I just recently did, so I just wanted to put them in just so you can see that I'm on a day-to-day practicing what I preach. So no distal occlusion, patient over time developed a crack. You can see here, this would be classified as no value, old restorative material, temporary material, even this right here, that occlusal enamel. You can see the decay there. Completed the case, placed a nice fiber post. Some may argue fiber versus metal. I used the fiber just to kind of mimic more the modulus of elasticity of dentin. Just based on this case, was able to bond my core. Obviously, the stained with the methylene blue, you can see that crack, but it did not extend down into the furcation. So we'll see what happens. So I was under isolation, restored the tooth, sent it back to the general dentist. Please restore ASAP with the permanent crown. Now we all hopefully are doing well, double vax, triple vax, whatever's your fancy. But what I would say is that none of us expected to go into a pandemic where we would not be able to access the dentist at will. God forbid something like that should ever happen again. What I'm saying is that I've seen so many patients that are in a transient lifestyle. Maybe they're tourists coming in town, flying on their way to a film shooting, you name it. It's just a transient city. And so having the confidence that at least I did my part to give the patient the best chance for long-term success, or at least some sort of success after they leave my office, it feels good, because once the patient leaves your office, that's pretty much it. You have no more control over the case. So let's just kind of look at the glossary of terms when we look at modern endodontic access. Okay, these are the ones in red that we really want to stay away from. Green is highly valued. Black as well, pericervical dentin. And the red we want to stay away from. Inverse funnel, that's what you're going to get when you use the round burr. Gouging and blind tunneling, arbitrary round shaping. Like I said, I have pretty much done away with any round burrs. Obviously, sometimes they're still useful, gross excavation of caries, but I tend to be a little bit more thoughtful now, especially since I'm under the microscope, and I tend to use that tapered diamond just to really kind of feather away those areas that need to be removed. So this was a more traditional access that I used to do. Little void there, excuse the blind spot. But this is what is a good example of that kind of funneling technique and gouging. So nowadays, I would want to respect more of this tooth material here, this dentin, and keep more of that intact. Set my point of negotiation from this mesial pulp horn down, and then from the distal, just like that, to have a more conservative access, preserving more of the pericervical region, or the region which we deem as highly valuable when we're talking about the hierarchy of tooth needs. So again, things we do not want, non-desirables: inverse funnel, blind tunneling, arbitrary round shaping. Not to say that these cases will not hold up, not to say that this is not a good case. This is still acceptable by any standard. We're just saying that, well, I'm just saying that now I am a little bit more critical in my thinking of ways to preserve dentin before I cut my access. So I'm not saying that how I'm practicing is necessarily much better. I'm just saying that based on cases where I felt the tooth maybe could have had a better chance at long-term survival had I adjusted my thought process, that's where I'm at within my career. That's the point where I'm at. So this is going to be a soffit or a stepped access, okay? Traditionally, if I saw this old amalgam restoration, I would go right here and just go right down and disregard all of this dentin right here. That's how I used to cut my access. And again, there's probably nothing wrong with that. It's going to give a crown. However, the studies are not showing that there's any significant difference between conservative access and traditional, but nonetheless, I still want to see how I can do my part to conserve dentin, because we know that structural failure tends to be one of the leading reasons why teeth fail. So what I did was I cut my access, my points of negotiation. So you can see I went right here from the distal. Nice conservative shapes. I believe this was a 2004, 20 diameter and the 04 taper. This would have been probably 2006 in the distal. And with new irrigation techniques, we can actually expect to clean and shape those canals to a high level. And now I can restore that case as such and send it back to a general dentist. Or sometimes you may not even need to have that tooth restored, but I'm always in constant conversation with the general dentist, and we're kind of deciding what's really best for the patient at that time. Here's just a little bit of how I treated the case. Here's the old amalgam. We understand that that is no value. So I excavated that just to the level of healthy dentin, okay? That's kind of what we call partial de-roofing. And then from there, I set my points of negotiation. If you look right here in the mirror, you can see all this healthy dentin still intact. And because I'm using high flex EDM files, which allows me to have increased flexibility resistance to fracture up to 700% than comparable files, I have confidence in navigating and negotiating these these points of negotiation to clean and shape the canal. You can see here's the obturation, and of course, final completion. Here's another case, old amalgam restoration. This was another case of SIP-SAP, cracked teeth. Like I said, I have seen so many cracked teeth throughout the pandemic. So we really want to give these teeth the best opportunity to, to be retained in the mouth if that's so is the patient's desire. And we understand that the best time to restore the tooth is at the time when the endodontics is completed and it's under isolation. So I spoke with the general dentist. We were on the same page, found MB1, MB2. They merged together. Again, de-roofing, partial de-roofing, cut my soffit, filled that up, and placed a resin tag down into the palatal to hold the cord. This is just a slide discussing some of my access burrs, but this next slide is really going to give you an idea of what I'm using. So I have a smaller, small head football. You can see here I have my 1558G. That's my carbide, very small diameter, very good at obviously removing restorative material and cutting into the axis in a quick and precise manner. Tapered diamond, the 856 is going to help me access in axial directions. And then, of course, every now and then I still may need to use a safe end. I don't use this often. I've developed a nice tactile sensation where I can still respect the natural anatomy and not gouge. But if someone is just starting out, I can't speak highly enough for the 152 EZ-FG. Just think of it as the safe end burr. Debridement, we don't need to go on that too much because I'm not going to talk about cleaning and shaping, just more or less highlighting some of the cases. So this was another case, as you can see, a significant dilaceration. Now keep in mind, contact is always important to protect the gingival tissues, but if the patient is going to be receiving a crown anyway, sometimes we can actually forfeit on the contact, and we understand that based on the type of matrix you're using, just for ease, I'll oftentimes reach for a Tafelmeyer. But the challenge that I find with the Tafelmeyer is you kind of get that kissing contact. You don't get that real, the kissing contact right at the occlusal surface. But if you want the more broad contact, sometimes you have to either modify that Tafelmeyer, if it's like a deep margin, or maybe you have to go for a sectional matrix system to actually get a more broad contact. So I stay with the Tafelmeyer just because ease of access, familiarity, but you do have to have a depth of armamentarium in terms of matrices to manage a lot of these cases. And I think I'll highlight that. So here's a case, perioendo lesion, necrotic pulp, acute apical abscess. You can even see that we had some furcation, even there was involvement with the neighbor's probe, slight mobility. So this was a case at first glance when I highlighted this for the residents in my program. More than half of them voted to remove and extract that tooth. Let's give the patient some options. Dual access, just to try to preserve as much of that pericervical dentine as possible. This is one of my earlier cases, so my precision was not as clean, but nonetheless, the goal in mind was still what I was working towards. Obturation, you can see through both canals, through both access. So there's a nice little schematic of how I'm actually debriding the pulp chamber. As you can see, I have a 90-degree angle ultrasonic tip, and I'm getting right underneath that furcation, activated sodium hypochlorite, ultrasonic irrigation. Nowadays, I use gentle wave technology on certain cases, and it has enhanced certain aspects of my cleaning and shaping. It's not something that I go to all the time, and I'll talk more about what that is, but it's just an advanced irrigation system. Like I said, multi-sonic irrigation, so it's going to use sound and also vibration to really activate, and there's going to be negative pressure, so the fluid dynamics of the machine itself, the technology, clean from orifice to apex and in a very predictable manner. And it's great technology. This is just my basic armamentarium. Nowadays, I'm using more or less a dual cure, or maybe just like a one coat sort of prime and bond. I love the tapered fiber posts. So that was immediate post-op. Nice resolution of that furcation. So we're seeing that a lot of these teeth can be saved, and patients want to save their teeth. Now, just because I restored the tooth does not mean that I'm still not going to make a recommendation to visit the dentist for a crown. At the end of the day, I can assess restorability when I'm under the dam, the tooth fracture, or is it not? What are the questionable concerns? You know, is there invasion of biologic width? Is it a deep margin? But ultimately, they're going to make the final determination. We're going to crown this tooth because we understand that you have, in molar occlusion, you have a parafunctional habit of your grinding, your clenching, or you know, your excursive is problematic. Whatever the case is, that's still going to be deferred to the general dentist, and they're going to make that decision. So they're still always going back, but at least this way they're going to have protection as they journey back to get that restored. I think I started off with this case. Maybe no, this is a similar case. Furcation involvement again. Little abscess there, little draining sinus tract, and I love to trace that. Actually, the literature we used to quote in residency was Kelly Ellinger. It was a case where it was like a premolar, things like maybe a first premolar, and they wanted to actually treat the tooth. So let's say it was 4, but when they traced the tooth back, they actually found that that was like 2 teeth over where the sinus tract was drained from. So it's very basic, but I still love tracing the sinus tract just for giggles, and it's nice to show the patient as well. 3 distal canals here. Obviously, at the microscope, you can see that. Still under isolation, so we feel very confident that aseptic technique is being honored. Calcium hydroxide. Stay with a lot of that. You can see I overexpressed it. Sometimes that happens. You know, you can get necrosis of tissue down there, but in this case, nothing like that happened. But always warn the patient they may have a little bit more stormy post-operative recovery, but a little expression of the calcium hydroxide is not the end of the day. Again, there's my basic Toffelmeyer. Stepped isolation and access. Etch. Let's see, is there etch? Dual cure. Check occlusion. And then we see 5 weeks before and after. Yeah. So that was the immediate post-op. Remember, I had placed calcium hydroxide for about 3 weeks, and we can already see furcation filling back in. So perio-endo, yes, but we treat the closed system first, and we can expect to get resolution of the periodontium because we understand that the etiology was based within the endodontics of the case. I'm going to wrap up in about 10 minutes. Just want to get through a few more cases. SIP-SAP. Number 30, suspected crack. So obviously we're going to still recommend crown after. Dual access. Completed that case. Minimally invasive obturation. Restore under isolation. The truss access. This is the axial view on the scan. You can see 4 canals. We're looking at tooth number 3. Became symptomatic after MO prep, most likely due to some sort of invasion of that mesial pulp horn there. Could be maybe even the distal. It's tough to say. You never understand why. Actually, good paper by Abu Ross. Prosthodontist talks about the stressed pulp condition. And before we move to any restorative work, if a tooth has any prior work on it, we should always evaluate that tooth, get a pulpal status before doing any restorative work, because oftentimes after the tooth becomes rather symptomatic. Again, minimally invasive endodontics is not necessarily saying what's the smallest access I can make. It's just stating, where can I respect dentin? I was in a good mood. I felt comfortable. I created a very small access, but I thought I was still able to negotiate into my canals. And so, yeah, went ahead and was able to obturate that case. And I need to follow up on that, but I haven't heard back from him, so hopefully that's a good thing. We can see just the access cavity was very conserved, minimal engagement, trying to respect as much of the pericervical dentin as possible. And keep in mind, my practice, I probably restore maybe 40, 50% of cases. You know, I'm still an endodontist and I just get in, do what needs to be done. But there are certain practitioners I work with, and they value that I am looking to restore the tooth, especially when it's a deep margin, number 15, sub G. Maybe you want to do it, maybe not, but when I'm under the scope and I can visualize what's going on, clean those margins and actually show that so we take photos, you know, these kind of cases are fun to complete. And it's a nice little tandem handoff. Lateral canal address, you can see more or less a conservative with that tapered access again, because I'm using that 556 and restored. This was a cracked tooth. You can see that distal bone loss there that represents in the skin. You can see that there, that vertical defect. So again, the cracked tooth is a challenge. That's why I placed a bonded resin down into the distal canal in hopes that that's going to help create a seal. Crown is still recommended, but we just want to keep as much of the tooth intact to prevent against fracture. Retreatment, silver point removal. Just go ahead and restore the access through the crown. Sometimes I'll do that just to provide a nice seal. We'll see how that heals up in the next few months. I just recently completed this case, I think about a couple weeks ago. Caries directed access. Again, you can see the caries here. Bite wing, not the best bite wing, but we can see that it is going to be below the gingival margin there. Excavate decay, you can see 1, 2, 3, 4. Palatal will be over here, was able to still engage, or I should say negotiate my canals, still maintain a lot of that tooth, when usually I would almost just completely demolish all of this in order to get into those canals. Restore, and you can see nice, sound, tight seal. Send them off for the crown. Feel much better about not having to deal with micro leakage. Tooth is not leaking as soon as they hit the subway, and ultimately, hopefully, we can save these teeth. Access through the crown. This was a more robust, kind of larger, but that's because this was a significant calcification. I was having some difficulty trying to orient myself, so I opened it up a little bit wider. But you can see the goal was still maintaining pericervical dentin, thin tapers, and clean shapes. Just completed this case for a patient, no, actually a dental assistant. This was her mother, and she said, hey, you know, if you guys could just help me out. And you know, it's just a matter of preference, but I like to try to really create a certain value for practices that refer family or refer, you know, colleagues. So it's nice to have that trusted opinion when they send those cases. And I was able to get in there. Very challenging because the mesial inclination of the bridge was concerning. But you see, I was able to still maintain a lot of that dentin, keep a lot of that intact, manage that shape, manage that S curve, and restore the tooth as necessary. So now all she has to do is just go back to get a check, make sure that the gingival, she can keep the gingival area clean, and she's good to go. So, I was going to talk about this, but that's for another time. Just focusing on that is the high flex file. Controlled memory is really the selling point. Up to 700% greater fracture resistance because of the flexibility. And I'm just going to show you a case in point. You can see it's going to be able to hold that shape. This was a case where I actually had to get in there around the post. This patient was complaining. She was an active exerciser. Doc, I'm still having sensitivity when I exercise. I get a throbbing. Please save my tooth by any means necessary. I don't know how I'm going to get around that and not take out the post. You can do it. I have confidence in you. Okay, if you do, I'll go for it. Not the most sound obturation, but the goal was accomplished thanks to the fact that I was able to use the controlled memory to actually get in through this access and find the canal clean, shape, and fill. So new files, new technology, it really just helps facilitate dentin conservation. We understand the value of irrigation, but we understand at best, we're going to only be able to address so much of the canal anatomy. This is just a overview of a tooth slice by Dr. Ove Peters out in California, just showing that we really do not clean as much of the tooth as we think. And that's why we're seeing a lot of advances in irrigation, lasers, gentle wave, things of this nature, because we understand that if we can eliminate the bacteria and provide a optimal environment for health, oftentimes the apical periodontitis will resolve in a timely fashion. So that's just irrigation, a few things on that. Of course, I would not be an endodontist if you didn't see me practicing under the scope. Should probably have that mask up, but that is me in action. It's just a nice case, calcification. I told the patient she's going to need to get a new crown. I was concerned about this area, which is actually on the buccal aspect of the tooth. She's like, just do what you got to do. Dentist was on board for right now. Go ahead and restore the tooth, with alloy. And so what I did was completed those 4 canals, cleaned in shape, and then just a little amalgam plug and sealed it back up in hopes that at least it'll grant her some time until she can get back in and get that tooth properly evaluated and see what's the next step in terms of restoration. That's just, I just want to show you this before we close up so you can understand how the files work in action. So this is a case isolated, very limited opening. Can barely really even get my mirror in there, and that's a size 2 mirror. This is an orifice opener. Usually how I'll start my case, just kind of get in there. It's no longer than 16 millimeters. Just quickly open those canals up. You see, I'm kind of putting a slight bend, getting in the canals. Yep. Nice sweeping motion. We'll move to the next. Oh, yeah. Gauging my working length, getting in there real quick. Now this is what I want to show you. Look how I'm putting the bend on this file. You see that bend there? So I can actually kind of get into that mesial buccal and clean that out. Actually, that may be the distal I'm getting into. But with this new technology and advances in metallurgical sciences, these sort of cases become more predictable. And this is a cordless handpiece, which allows me to really function well. The ergonomics is helpful. And I'm a rather tall guy, and I use the scope, but I always want to be aware of my posture. And so using these files as well as the cordless handpiece has been a lifesaver. Again, if you look at that, you can see I put a nice bend into the file. Cleaning and shaping, just getting in there right around that curve. See the nice bend, and it holds that curve. And then I'm good to go. So that's just a little bit more of the same. I'm going to show you too much more beyond that. This is a simple trick many of you probably know. Sometimes it's hard to determine if the canals join. If you look into this mirror right here, you'll see the hydraulics up and down. So that just gives me peace of mind. Hey, I'm going to go ahead and fill the mesial buccal And wherever the lingual stops, I'm good because I know they join. But, you know, I always just like to show that. It's always just a fun trip. So again, minimally invasive endodontics. Like I said, I don't restore all of my cases. This is more or less my bread and butter. Just get in, thin tapers, thin shapes, respect the anatomy of the tooth, send it back to the restorative doc. Again, just some more cases. Buccal access came in from the buccal here, restored the tooth. You can see nice, probably, I don't know, it's 60-degree angle on that. There goes the truss access. Nice clean shapes. Restored the tooth. This is a mesialized access, didn't conserving access, didn't directed access from the mesial. Still keeping that distal shelf intact, respecting as much as possible of the pericervical dentin. Obviously, crown is recommended, full coverage. Good clean margins. This is subgingival. You can see a lot of heme, the caries. Clean that tooth out, excavate, and now you can see we'll be able to get into the pulp horn. Minimally invasive endodontics, just a small access that allows me to gain sight into the canals here. And I think that brings us to the last one. So the question is less really more? Only you can make that, only you can answer that for yourself. However, this is the new shift, the new trend that we are seeing within endodontics because the emphasis is on patient outcomes. And as long as we always put patients first, profit will follow. These are just new and exciting creative ways using new technology, imaging, as well as metallurgical advancements to really creatively save teeth in a predictable manner and in a relatively pain-free environment as well. So I really enjoyed the presentation. Thank you so much for allowing me to share what I do on a day-to-day basis. Like I said, I've been passionate about dentistry since I was 11. So right now I'm really living the dream and I'm learning more and more every day. And I can't wait till we can really have these discussions in person. And hopefully I'll be invited back when that time comes. And thank you so much to the leadership. Of course, Eugene, Porcelli, President now, Bross, and of course, everyone else who's a part of the Nassau County. That's where I started my endodontic career. So it's always nice to be welcomed back. And I really hope you enjoyed the presentation and just leave you with a few points of wisdom and inspiration. Lift as we climb. As long as we elevate the profession of dentistry, we all win. So it's not trying to separate endodontics from general dentistry. It's just saying that there are different ways to achieve the same outcome. And when we work together, it's amazing how we can really benefit the general public and the profession of dentistry in general. Thank you.
Thank you, Marcus. I do have one question here. Do you use loupes at all or just the microscope?
99% of the time, I'm under the microscope. Loupes, I felt, based on where I like to sit comfortably, I was always tending to lean more forward, the mesial inclination, if you will. So the scope is my everyday staple for most cases, okay, pretty much 100% of cases.
Very good. All right, I don't have any other questions. I'd ask you if you could stop sharing your screen.
Okay, let me find that.
Right up on top, it should be a red box says stop share.
Yeah, I remember I kind of did away with that word when. Maybe let me see the show and maybe I can find it.
Marcus, I want to say you did a great job tonight. And
thanks, Joe. Can I give you your screen back? I can't. I'm sorry. I don't know what happened. It's a Zoom. Am I still there?
Yeah, your screen is still on there, yeah.
Interesting.
Yeah, there should be a square, you know, where it says share your screen.
It must have disappeared.
Upper right-hand corner where it says share, click on that.
See where it says view options? And there's you don't have the green box up there, say sharing?
No, I don't have that.
Minimize the screen. Minimize.
This is my desktop. It's minimized.
All right, let me see if I can do it for you.
I think you can under view options. I think you can do that.
Yeah, I think you can do that. Yeah.
It's stop participant sharing.
Okay, good. There we go.
Okay, we're good. You see my screen now?
Yes, we do, Chief.
Good.
Do.
Do we need to sign out?
Well, don't sign out yet. I've got a couple sponsors, and then I'm going to put up the link for the evaluation. That's how you get credit. So our first sponsor is Fox Pest Control. I'm just going to play their video real quick.
There it goes.
Maybe not so quick.
Not so quick.
There we go. All right, this worked a lot quicker when I tested it out. All right. I'm going to move on to the moment to our next sponsor, Eric Payne. Eric, I'm going to ask you to share your screen. He's from Tech-A-Go-Go. Eric, are you there?
Yes, I am.
All right, so I'm going to start sharing so you can share.
Sounds great. Dr. Johnson, great job. One of the things that you do, it seems like your central theme was about technology, systems, and simplification, which is really, you know, this world right now, after being hopefully coming out of the pandemic, just oversimplifying what we do and having systems in place to make things easier so that you all can produce the most dentistry per hour as possible. I think it's fantastic. So great job. I love seeing technology in the dental office.
Thank you.
I know you guys are, Ron, can you guys all see my screen okay?
Yep.
Perfect. So again, my name is Eric Payne. I'm the founder of a small little startup here called Tech-A-Go-Go in the Silicon Valley in the California. Spent about 20 years working for one of the nation's largest healthcare distributors and saw a real need for change in one area. And it really was connecting technicians in the field directly with the dentists that they need to serve. I took the on-demand economy that is ever prevalent in all of our worlds right now with the DoorDashes and Uber Eats and Uber and Lyft for that matter, and applied that to the dental space. And so I just want to show you a couple quick slides, quick video, and then answer any questions because I'm sure you guys will have a few. Traditional model was really caught up in and around distribution or phone calls that you'd be making to get technicians in the office. Harassed a bunch of my friends for some money, built a big piece of software, and now the technicians in your area, just like Uber, you can be contacting them directly from your desktop in about 90 seconds. So much like the of our world, the on-demand economy is here. It is definitely not going anywhere. And it's even in our dental space. I mean, you can have your curing lights tested with your smart device. I figured, why can't we be in that space, and why can't you as practitioners have access to those technicians truly at the point of need and at the speed of need? And the emergent nature of your request for that service technician should be judged by you and you only, not some dispatcher out of Enid, Oklahoma, judging whether or not Op4 is truly important for you to have up or not. So I got a short little video, and then I'll come back, and I just want to see what you guys think. I'll just speed through that real quick, and let me know. You guys can hear the sound okay?
Okay, team, so let's have a great Monday. We have a jam-packed schedule, so let's get started.
All right.
Have you ever seen this many patients in one day?
Not personally, but don't worry, we'll be fine. So you want to go get the equipment turned on and get started in room 1?
Done and done.
Oh, shh.
Should we call someone?
Hi, this is Dr. Flanagan's office. Our compressor is down. Can you get someone out here right now to look at it? What do you mean, do I have a backup? It's a compressor. Who has a backup compressor?
I gotta get out of here. I gotta get out of here.
Calm down. You've got to get a hold of yourself.
Cindy, please, let me take care of this. Calm down. You've got to get a hold of yourself.
Not until tomorrow? We can't wait that long. We have a full schedule today.
How are the patients doing?
I won't deceive you, doctor. We're running out of time.
Surely there must be something we can do.
I'm doing everything I can. And please, stop calling me Shirley.
If that's the best you can do, I guess we have no other choice.
So that is our entire team, by the way. They're not paid actors, and nor should they have been paid. They weren't very good at a lot of making the video. The reason we made the video is because in my experience, and you guys have probably all experienced the same thing, you've had these manic Mondays where you come in, your vacuum doesn't fire up, and you make that phone call to dispatch, and you get put off for a few days. So that is kind of how Tech-A-Go-Go was born, and it truly is service at the speed of need. So right now we've got about 60 technicians on the platform. Our average response time is just under an hour and a half in the major metros that we're in. And the calls here are usually picked up in about 4 minutes. So you can see that we've taken technology, implemented systems, oversimplified it so that you guys can truly be up and running and practicing dentistry, not being down waiting for your repair guy to walk through the front door. So that is my 2 cents. Again, I really appreciate the time. I know it's late where you guys are. I will actually be on a plane to y'all to bring on some more techs in the New York, New Jersey area Tuesday morning. So I may be popping in to see a few of you as I make my way around a few states and then off to the Chicago midwinter. So with that, I would love to take a few questions. If you have any, fire away. You guys are an easy crowd.
Yeah, I don't see any questions.
All right. Well, I appreciate your time, guys. Keep an eye out for us.
I'd ask you to stop sharing your screen.
You bet. Good.
And I believe there was a promo or something that you were offering Nassau County members?
You got it. So the promo code, and I'll put it in the comment sections, is NCD November Charlie Delta Sierra. So NCDS 22. It is a free hour of service, no strings attached. Sign up for an account, punch in that promo code. If you've got that Post-it note above your sterilizer with drifting x-ray and leaky air water syringe, we will address that for an hour for free. It won't cost you a dime, and give you a chance to experience us and how the whole flow and call cycle goes.
All right, so I'm going to stop sharing for 1 second so I can put the link to the evaluation into the chat area, and then I will start sharing again so that I can put up the QR code for you. So again, this is the QR code. That's the easiest way to get to it. But if you want to go in the chat room, click on the link I just put in there, and that'll bring you right to the evaluation. Please fill it out, submit it tonight. And in the next day or two, I will get the course completion certificates out, and I will also submit to NISDA for you. Are there any questions?
Yeah, could you, how do we get the form? I'm kind of missed. Where am I clicking? What's the link? Which is the link?
I'll hang on. I will put it in there again.
It's in the chat?
Yep.
Ah.
I did. There you go. You see it now?
Yes.
Good.
Thank you.
You're welcome.
Gene, it's blocked.
What's blocked?
The link, HTTPS forward, there we go.
Well, I mean, if you're looking on the screen, it's easier to click on it and chat. I'm putting the screen up mainly for the QR code that you can use your phone for. But however you want to do it.
Got the bar up on the QR code.
Can't open the link, Gene.
It works, Gene. It worked fine.
Okay.
Can't open it, Lee.
Well, what do you mean you can't? All you got to do is click on it.
Oh, now there's a blue thing part of it. There's a blue square part of it.
What do you click on? The square?
The link that's right there. If you put your icon, your cursor over it, it'll turn to a hand, and you just click on it.
And
I see the hand. It's blue, but it's not opening.
Not working.
It's not working.
No. I believe. And do you have your iPhone there?
Gene, it's not opening.
Do you have your iPhone?
No.
Okay.
Miss Beverly. /
Can't open the link.
Well, when I click on it, it opens.
Mine doesn't.
Oh, you couldn't put your name in there either before.
I know. I'm going to have to meet you at the next meeting. You're going to have to give me a little discussion on this. I'm having nothing but problems.
Anyone else having issues?
Oh, aren't I lucky? I'm as good
Can you just read the link because it's kind of blurry. It was kind of blurry on the screen.
I don't even have the link now. I just have all our pictures and the names.
Who wants me to read the link?
I do.
I do. But where do I put it in the chat?
Yeah, the link is in chat, but it's HTTPS, all lowercase, colon. I mean, I can put up the screen again.
I can't even open the chat. I see nothing but.
You know what, Perry? Email me. Just send me an email. I'll send you the link in an email.
Okay, thank you. And that's what, Nassau County with you?
Yeah, you can email it to office@nassaudental.org.
No more of these courses for me.
Once you fill out the form, you're done.
Fill out the form, submit it, and then you're done.
Okay, thank you. It was a great presentation. Thank you.
Thank you very much.
Can't get out of this stuff.
I just put the link up. It's right above your question. I'll do it again.
I can't get out of it. I give up on this.
There's got to be a better way.
Yeah, meet in person.
Yeah, that is the best way.
Why can't I get in?
Can you put the link up again?
Sure.
Just put it up on the screen. I can't see it.
It's if I put it up on the screen, you won't be able to click on it. If you go to
I'll tell
the
you
chat,
what. So why don't you just tell me what it is then?
it's you know what? Email me again at office@nassaudental.org. It'll be much easier than trying to read to you all these letters and make sure you do upper and lowercase correctly.
Nassaudental.org and just say I attended the meeting.
Just say, tell me you attended the meeting and ask for the link, and I'll email you the link, and you should be able to just click on it in your email.
Okay.
Office@NassauCounty.org or
office@nassaudental.org.
It's in the chat. Look in the chat. It's right there. Click on the link.
I can't get it. I can't get it in my chat. I'm on chat now. I see everybody's name. That's all I see on the chat. Let me see. Maybe at the bottom. No. I don't see anything in the chat.
I don't know what to tell you.
I know. I'm going to come in person. This is absurd. There's nothing you can say.
So I have the screen up again so you can see the link and the QR code. And I'll be honest with all of you, the QR code is the easiest way to do it. If you just use the camera in your phone and aim it at the QR code, you'll go right to it.
It says forms.office.com.
Right, forms.office.com/r/V5H lowercase j, capital Z, lower Y, 7, capital V, capital G, U.
It's not just going, you take your photo of the QR code.
If you use the photo app on your phone and you aim it at that, you'll have a little box there that you click, and then when you tap on it, the form will come up.
Okay. Now I took a picture of the.
Oh, I just got it. I got my camera.
You don't even have to take the picture. You just aim it at the camera, and then on your screen, a little box will come up.
Okay.
If you aim at it, a little yellow box comes up, formsoffice.com.
No.
Tap on that little yellow bar, and the form will come up.
You think so?
No? It does all the other times. Anyway, besides Perry, is anyone else having an issue here?
Isn't that great? It's my camera. I took the picture. I have it.